All right, good afternoon, everybody. My name is Dr. Jerome Gallia, coming to you from the School of Social Work at the University of South Florida, where for the past year or so, I've had the great opportunity to begin a research lab called the Access Lab, in which many students from social work, but not only social work, from across campus, including the College of Public Health, also participate. And as part of this lab, whose goal is to increase access to mental health services for all who need it, many of the students are also involved in related research projects. One of those research projects is, and I see many of you are from that project, is called Positive Connections 50 Plus, in which, along with colleagues from University of California, Riverside, and other NGOs are working together to develop a virtual space for people living with HIV, aging with HIV, aged 50 years old and older, a virtual space to help combat social isolation. Well, as part of that study, I see Brandon Brown is here, the principal investigator of that study, was invited by the Current Opinions Journal to produce an article on the current status of behavioral, social, and psychological issues for people living with HIV. And one of our lab members and doctoral student, Eric Ruiz, took the charge of working on that, along with another member of the lab, Kara Green, of course, Brandon Brown, the PI, and I was also involved in that. And actually, I think this paper was probably the fastest paper that I've ever worked on. I think the invitation came around October or so, and the paper was due by the end of the year. So really, there was just 2 months. But it was a great experience, and the paper was just published. And so for this inaugural presentation for the Access Lab Journal Club, it only remains for me to introduce today's presenter, Eric Ruiz, who's a PhD student at the College of Public Health and a very active member of the Access Lab. So I'm going to pass the presentation microphone to you, Eric. And so we'll allow Eric to present the paper first. And then there'll be time, we hope, for conversation and dialogue. Our hope is to make this kind of formal in the beginning, so we can kind of share with you the latest science, but then also have it kind of informal and be able to discuss things that maybe Eric will talk about, but also just kind of the more general topic, or you can share lived experiences as well. So please join me in welcoming Eric Ruiz.
Good afternoon, everyone. I'm going to go ahead and share my screen. There we go. Very good. Well, thank you to everyone here for taking the time out of your busy schedules to be with us here today. As I present this recent publication, as Dr. Gallia mentioned, it's called From Surviving to Thriving, the Current Status of the Behavioral, Social, and Psychological Issues of Aging with HIV. As you mentioned before, this paper was recently published in the journal titled Current Opinion in HIV/AIDS. I'm pretty sure that the hard copy of the issue will be coming out shortly. But before I begin, I really want to express my gratitude to my collaborators and mentors, Dr. Gallia, Dr. Brown, and of course, Kara Green, for their endless support through this process. All right, here we go. So essentially, this project was a review of the current literature that centered the biopsychosocial aspects of aging while living with HIV. I will describe this process in a bit, but to contextualize our findings, I want to share with you some background information first. Overall, there's been a 23% decrease in the global incidence of HIV. However, despite this remarkable success, there are still 38 million people around the world who are currently living with HIV and experiencing various levels of burdens. Although antiretroviral therapy has dramatically increased the lifespan of people living with HIV, over 1/3 of these people do not currently have access to this life-saving treatment. Furthermore, even for those people who are living with HIV who have access to sustained and consistent antiretroviral treatment therapy, the aging process we found can exacerbate HIV-related burdens. In our review, we found that the biological and psychosocial physiological aspects of aging with in older people who are living with HIV were well described in the literature. And these include concepts such as hardiness and frailty, cognitive decline, and systemic inflammatory processes associated with taking ART long-term. So our goal for this review was to identify the behavioral, social, and psychological barriers of successful aging in older people living with HIV, to contextualize these issues within the grander scheme of this idea of resiliencies that are present in this population, and finally to recommend future directions for research and intervention work. And just to help orient you as well, so for us to help make sense of what we found in the literature, we relied heavily on the 2019 Vance et al.'s revised biopsychosocial model for successful aging in older people living with HIV. And essentially it identifies 9 interrelated domains important to the process of successful aging, such as mental health, social competence, personal control, and life satisfaction. And as we're thinking through this process, an essential aspect of this model is that the importance of how each of these individual characteristics are distinct or discrete, but how they relate and interplay with each other in order to form this idea of successful aging in older people who are living with HIV. And that also presents this idea of opportunities for intervention. Now that we have a little background knowledge, we can move on to sort of the process of how we completed this review. Our findings were based on published scientific literature that we found using an expedited scoping review process. For those of you that don't know, this process is different from other types of reviews in that instead of searching for and identifying literature that addresses a specific research question, we are instead interested in finding and reviewing as much information as we can on this particular topic. So the biopsychosocial aspects of aging for older people living with HIV. To do this, we searched databases for literature that related to the biopsychosocial aspects of aging. We searched 3 primary databases, including PubMed, PsycInfo, and CINO. This image that I have here for you is it's a helpful tool that I use in the research process, and it includes our search strategy that we had to refine to locate all of this literature, and it also includes things like controlled vocabulary and special quirks that are unique to these databases as we went through this process. So after the initial review, we identified 1,012 related papers. In order to hone that down to topics that were related specifically to this review, we went ahead and did a paper title and abstract review. We removed duplicate papers. We removed papers with unrelated content. Removed papers where we did not have access to full documents, ultimately resulting in a total sample of 83 papers that we included in this review. And the rest of this presentation is essentially our synthesis of the findings from the literature that we identified. And just to give you an idea, the inclusion criteria included papers related specifically to the topics of interest, specifically focusing on older people living with HIV. So for our process, our purposes, we define that as people who are age 55 years or older. And then the last one, which is unfortunate, but just sort of the nature of our abilities, it was for papers that were in English only. So the results of our review were written in 4 main sections. First, the barriers to successful aging for older people living with HIV. resiliencies that were present in this population, interventions that focused on successful aging, and then lastly, future directions or what we perceived as our recommendations for future work. In this first section, we found that there were several barriers to successfully aging in older people who live with HIV, and these can be characterized in three main aspects. First, physical, then psychosocial, and lastly, systemic. These aspects had negative influence on older people living with HIV's social interactions, sense of personal control, mental health, and quality of life. So you'll see here, this figure is the one that actually we drew, Kara Green actually from our team created for publication. These are the actual documents or the actual images that we used. So first, thinking about the physical aspects included issues such as the role of comorbidity or suffering from multiple physical and mental ailments at the same time. The commonly experienced and taxing role of fatigue, both associated with the aging process itself as well as with management of HIV. And how aging with HIV has negatively impacted older people's living with HIV is their body image. And so this idea related specifically to the idea of long-term antiretroviral therapy use, which has been associated with this idea of, it's called lipodystrophy, and it's essentially where body fat accumulates in certain areas. The ones that people seem to be most concerned about were those that were really visible. So the belly was a significant issue. Next, moving on to the psychosocial aspects of aging with HIV, we found that they were interrelated in many ways. First, a very large study found a positive association between having an HIV diagnosis and poor mental health outcomes, including depression, anxiety, post-traumatic stress disorder, and substance use disorder. Furthermore, older people living with HIV had fragile social support networks and were susceptible to poor quality of life due to shame and loneliness. And this idea of shame was important because it may be related to stigma that older people living with HIV experience, related specifically to fear of disclosing their HIV status, rejection, and stereotyping. Lastly, this idea of systemic barriers to successful aging included sort of highly related topics. Primarily, we saw that poverty and low socioeconomic status was found to be a significant barrier to accessing services related to physical and psychosocial aspects of treatment. HIV status has been shown to adversely affect employment status, which may further endanger sort of the financial stability of this group. And lastly, older people living with HIV with fewer access to resources, including those financial resources, may be susceptible to other sort of downstream issues such as food insecurity, poor nutrition, poor quality of life, and then poor mental health outcomes. So I know this previous slide was, demonstrated a lot of significant issues to successful aging for older people living with HIV. But I sort of want to contextualize those within this broader idea of resiliencies that exist within this population that can be used to leverage, that can be leveraged for use in terms of intervention development or identifying specific issues to overcome these challenges. So for our review, we define resilience as the ability to adapt to adverse life events and their associated consequences through the capacity to cope. The literature had many examples of these resiliencies that could be used to reduce mental health stress and increase coping in this population. And these included issues such as improved psychosocial perceptions, such as self-acceptance, generativity, independence, and optimism. And I just want to briefly take an aside to highlight the idea of generativity. It was first described by Erik Erikson and is an important concept that's used in just the general gerontological literature. And it is defined as the desire to foster an environment that will benefit those that succeed or come after them. And in our review, we identified a study that had a relatively small sample size, but it described how older people living with HIV perceive themselves as both pioneers of the aging and living with HIV process, as well as mentors for younger people who are living with HIV. And I just thought that was like a really significant and beautiful aspect of having to navigate both of these issues at the same time. Moving next on, so much of the literature that examined resiliencies in older people living with HIV noted the importance of social support in mitigating the poor mental, physical health that these people experience, as well as quality of life aspects experienced by this group. Some studies found that older people living with HIV tended to rely on social support networks made up of primarily family and friends. And I thought that this was interesting because romantic relationships were like especially identified as not being included in these social support networks. And then others highlighted that the challenging relationship that some older people living with HIV share with religious organizations. I thought this was interesting because for some, the benefit of social support and community engagement they found in what was called as safe spiritual places help reduce the burdens they experience, but for others, participating and engaging in religious organizations left them with a feeling of being shunned. And they identified this primarily as being related to the social stigma associated with having an HIV diagnosis. So given our current understanding of the barriers and facilitators to successful aging in older people living with HIV, for us, as we were doing the review, it became clear that interventions designed to facilitate successful aging needed to address the unmet physical, material, and psychosocial needs of what is really like a diverse and burgeoning population. These interventions should be informed by research designs that adequately assess these needs, as well as sort of matching those needs with the preferred modalities of intervention. Some researchers seeking to improve successful aging in older people living with HIV have called for the incorporation of a life course and strength-based perspective to better address these needs of this population. And this is important because it really shifts the focus of HIV and aging, like from a pathological lens, so as something to be treated and cured, to one more that focuses on thriving while living with HIV. So as an example, the important role of social support in reducing physical and mental health morbidities and improving quality of life associated with this process is receiving increased attention, and this is significant considering that some older people living with HIV require additional material support, and interventions to reduce this barrier include the use of internet-based support groups, which is, as we'll see, gaining sort of popularity in terms of the research realm. Comprehensive interventions that target some or all of the domains of the biopsychosocial model for successful aging in this population have recently emerged as promising. An example is demonstrated here. So this is an image taken from the Golden Compass program, which is supported out of the University of California's San Francisco campus. And it is a comprehensive intervention for older people living with HIV that incorporates services and evaluation for a variety of issues. So cognitive and cardiology issues, physical functioning, dental, hearing, and vision, social and community building. And so far, their pilot study has indicated that this intervention is both acceptable and implementable within the population of older people living with HIV, as well as their care providers. And another example that I just want to highlight briefly, since my collaborators, Dr. Galley, Dr. Brown, and Kara Green, are all on this call, is this other project that Dr. Galley had mentioned previously, which is called PC50+. And so this program is seeking to address the supportive care, psychosocial, and information needs for older people living with HIV through the development and implementation of a virtual platform. So this combines the idea of having a comprehensive intervention that incorporates modalities that are accessible to older people who are living with HIV. And that project is still in the works, but stay tuned. So in reviewing the literature for this particular paper, several gaps that are I guess you could say, are missing in the literature became apparent. So future research should consider studying the ways to improve our understanding of the aging process in people living with HIV in a variety of populations. For example, there is a dearth of data estimating the prevalence of HIV and any sort of unmet care needs in older populations living in low and middle income countries. A majority of the literature that we reviewed and included in this review were from the United States, so North America, some Canada studies, and some European studies, but there was a noticeable lack of literature present from Latin America and Africa and Asia, really. So, more work needs to be done to assess the prevalence of HIV in older people living with HIV in those countries, as well as sort of the unmet needs that they may be experiencing. Additionally, this includes the idea of incorporating non-English speaking participants in research projects. Even within the United States, those populations tend to be underrepresented in the literature, and are an important part of this community. Additionally, our understanding of unmet care needs should include this idea of differentiating the needs of long-term HIV survivors compared to those who are newly diagnosed and are older. Additionally, the idea of needing more information regarding the needs of transgender identifying individuals. And lastly, the idea of incorporating more women into studies of older people living with HIV. A significant portion of literature focus on, cisgender white males, usually within the, the LGBTQ spectrum. But again, the specific needs of these two populations, transgender individuals and women, was lacking. And then lastly, although this field is rapidly developing in the context of delivery and implementation of antiretroviral therapies, we are still looking to see successful examples of interventions that address these psychosocial needs experienced by older people living with HIV. In terms of future directions, I just want to sort of reiterate some of these points that we brought up in the paper. So with few exceptions, synthesis of this literature indicates that for older people living with HIV who live in high-income countries, it may be that the aging process contributes more to the than the HIV disease process, relating to specifically their physical, mental, and psychosocial health burdens that they experience. In low and middle income regions, we really need to continue the work of improving access to antiretroviral therapies, and this may require more research to better describe these unmet needs in these regions. Again, shifting the focus back to high-income regions, we recommend additional attention be directed on the unique needs of individuals with intersectional identities. So this could include older gay men living with HIV, who may, on an individual level, request that their care providers be more knowledgeable about issues specific to their population, and then also to foster an environment that influences greater uptake of clinical services. In regions where healthcare systems are not equipped to adequately address these unmet physical, mental, and social needs, alternative routes of care should be considered, including this idea of community-based models. That's sort of, I don't love using the word empower, but really shift the focus of treatment for treatment's sake to what works for older people living with HIV, and also leveraging the idea of generativity in this population and their interest in self-managed care. Finally, as the population of older people living with HIV continues to grow, the role of comprehensive interventions targeting all facets of successful aging, meaning those derived from the model that I described, cannot be overstated. The physical, psychosocial, and mental well-being of older people living with HIV are inextricably linked, and interventions will need to be developed and implemented by collaborative multi-sector teams comprised of older people living with HIV, care providers, health psychologists, researchers, and community organizations, if we're to really push for this idea to move beyond the paradigm of survival, which is where we've been, for the last going on 20, 40 years now, to one that's more focused on thriving. Thank you.
Thank you, Eric. That was a great presentation on a pretty dense, paper. You said you and Kara reviewed over or screened over 1,000 articles, so it's no small feat to kind of condense that into was it 3,500 words or so. I would like to invite our audience here to raise questions. You can type them in the chat, or you can raise your hand, and I'll just so that we're not talking over each other, I'll just kind of call them as I see them. We'd really like to hear from really anybody. Maybe you're somebody with lived experience, maybe you're somebody who's just learning about this, or maybe you're someone that has found something that can contribute to this conversation. While you're thinking about that, and I'm waiting for that, I have a question for you, Eric. Tell me, what surprised you the most when you were reading these articles? I mean, was there something in particular that you're like, whoa, just wasn't expecting that, or maybe you expected it but didn't think of it applied to this situation? Is there anything in particular that kind of really grabbed you, interested you, excited you?
Sure. Yeah. So one of the issues that was brought up that wasn't heavily addressed within this paper was the idea of communication with care providers to identify specific needs that people may be feeling as they age and also manage their HIV. And I'm specifically thinking about the idea of if you can imagine, having a younger physician who's in charge of your care, and having these very, sort of serious conversations about these psychosocial needs that, are, at least from my perspective, in care management plans are sort of seen as auxiliary issues. But as was demonstrated in the literature that we reviewed, like maintaining and sticking to care management plans is highly dependent upon these psychosocial factors that often go unaddressed. Mm-hmm. How can you be sure that someone's taking their medicine on a regular basis if they don't have if they have to choose between buying that or buying food, or if they're disclosing of their HIV status puts their job at risk? In what ways can we ensure that they are managing the care in the way that they should be?
Yeah, that's a great point. It reminds me of some work we do also in the world of TB adherence, where we always say it's so much more than pills in mouth. It's just if we only look at it with that lens, we're missing like so much else. And so what you're really hammering home is all these other psychosocial issues and hierarchies that people follow. Well, I do see we do have a question from our friend Will Carter. See you. I see your hand up. Go ahead with your question. So I can't. No, I don't think I can unmute you. So just hit the unmute button. I think we'll use Zoom next time.
Okay, there we go.
There we go.
I have a question, a comment. It's like a combination. As like we gather here today in the different meetings that most of us go to, that as a person who is aging, with HIV, and I've been positive for, this will be my 24th year myself. I'm finding us older people who are growing older with it are a lot more knowledgeable of our health issues and aware of, and then finding physicians, as Jerome was saying, it's just not, popping the pill to your mouth. It's more than that. And how to find that delicate balance between that, and as a person who has done a treatment interruption for, I did it for like maybe 13 months, that what that does to a person that's not being able, that, not saying not being able, who did not take medicine for that period of time, what that does to a person's psyche, and then coming to have to go back on. How are are there any findings? How are they finding the coalition with taking medicine, going on and off, and dealing with people who happen to be knowledgeable of their health, unlike our younger counterparts who are just trying to learn how to even ask a question. Whereas I'll question everything. My eyelash is blinking too far to the left. Why is it doing that? You know what I mean?
Certainly. So I can thank you, Mr. Carter. I appreciate it. I appreciate your question. So I'll say two things. The first is that as of this review, our knowledge of that is developing. Most of the studies that we reviewed had smaller sample sizes. We're not focused on the idea of intervention, and really wanted to address sort of unique experiences of like varying populations of older people who are living with HIV. However, what I will say is that an issue that was brought up sort of regularly is this idea of social support, either mostly from like family and friends, but this idea that building a community of people who are experiencing things similar to you as you age with HIV has really helped them, stay adherent to their, treatment plans, but also, address a lot of these issues that aren't captured when you're meeting with your physician. You can actually talk, face to face about real experiences that you may share with other people that really gets lost, like in the physician patient dynamic.
Thanks for that, Eric and Bill. While others are thinking of questions, I have another one for you, Eric. You mentioned this concept that all us social workers talk a lot about, and this is generativity. This is the concept that as we age, we get value out of kind of giving back to younger people. What sorts of benefits were reported? I mean, the idea of kind of benefiting, is it a psychosocial benefit? Is it, I mean, was there anything specific that you found that really was mentioned that was specific to people aging with HIV?
Absolutely. So generativity came up just a handful of times, but in terms of direct benefits, I would say that it was more of a psychosocial, like a positive psychosocial outcome, in the sense that depending upon how you engaged with that perspective, let's say, for example, if you took up volunteering, that was really helpful in fighting sort of the social isolation that not just older people living with HIV, but older people in general experience pretty frequently. So staying connected, having people care for you, ask about how you're doing, check in on you, as you're going through these processes of giving back in whatever way you saw, was beneficial in that aspect. And just to give you sort of a more recent example. So I know that I mentioned PC50 Plus before. It's this project that I'm working on with Dr. Gallian, Dr. Brown, and Carrie Green, and a number of other collaborators. But we did a survey of our community advisory board, who's helping direct this research, and every single one of our I'm going to call them CAB, community advisory board members, they all engage in some sort of volunteerism, some sort of giving back for one reason or another. It be that going or attending to lectures, volunteering, providing childcare in one way or another. But I just thought I highlighted it specifically in this presentation because I thought it was such a beautiful idea, and there is like in the literature that we reviewed, there is a lot of like I'll just describe it as like suffering, related a lot to this idea of social isolation, and engaging in those social processes that help us get over that seem like a great positive route.
Thanks. Hey, I see a question from Char. Thanks for joining us today. Good to see you.
Great to see you too. It's not so much the question, but more like general comment. Perhaps
Sure.
I can get the sense and the input from the team. As a practicing physician that take care of a person who live with HIV, I can see that the care is really moving towards from infectious disease specialists or people who are trained specifically for HIV now into primary care, which I personally, as a infectious disease specialist, I really think that have general internal medicine or family physician take care of patient with a person who live with HIV is a better model and become more holistic. Perhaps on the group, do you have any ideas or input from policy standpoint how to encourage people to do that?
Great question. Great integrated care model question for the public health PhD student. No, but it really is. I mean, it's such a great question. That drift represents it's not drift. It's intentional integration, moving away. My guess is, Char, the idea would be to access ID specialists when you need something specialized. Otherwise, it's a routine managed chronic condition that can be treated by your PCP that knows the whole body. But Eric, what do you make of that question?
Thank you for that, and I 100% support this idea. If only because I know that primary care specialists or primary care physicians can also have that sort of broad level of training that includes mental health to a certain degree, and even being able to just refer people out to services or community organizations, depending upon how your own social network is set up. I think that's a very important and very pivotal issue. I do know that just from a public health perspective, that it just seems like primary care is really undervalued, and so it seems like as much as a policy issue as it is, it's also a cultural shift that we're having to work towards. So it'll take a multifaceted approach. I do think, though, that again, going back to this idea of intervention that's sort of holistic or comprehensive. So part of that goal is to incorporate both aspects that address the social support needs. So bringing together older people who are living with HIV, but also like having spaces for informational, like unmet informational needs. So having physicians come in and address specific topics to a larger audience, and then letting the group like just discuss and like what works and what doesn't, and how can I get the kind of care that I need. But yes, very, very important, and also increasingly dependent upon those states that have yet to expand Medicaid. But that's just me.
Thank you for that.
And there are two other. Oh, sorry, Char. Go ahead.
Yeah, I want to add one thing. Take care of HIV, unless there are issues. It's pretty straightforward now, because once a patient right now you don't have to go to any criteria to start on antiretroviral. You have pretty much only a few options that on top of the list, unless comorbid conditions will prevent them to use that or some side effects and things like that. I mean, baseline resistance is rarely ever happen anymore. So it's really pretty much infectious disease specialists had really not doesn't have a lot of role unless those issues came up. So I just really support that, and to have this more holistic approach, especially when the person is aging, that include mental health, uh, neurocog, and all those kind of stuff are very important.
So we have a couple other folks like to speak. So thanks for that. Thanks for that, Char. I mean, there are other good examples. I mean, what's coming to my mind is this broader concept of task shifting and task sharing. Really kind of these diseases which were once kind of more exotic, kind of making them kind of more mainstream and treated normally in the regular platforms. It also just occurs to me, it's like one less person, it's one less visit someone has to go to. It's like it's a one-stop shop model. But I know there are other comments, and I also see, Jeff, I know you're here and you have your finger on the pulse of policy. So maybe I'll ask Jeff, it looks like you have a comment, and then we'll come back to you, William. Go ahead, Jeff.
Yeah, sure. I mean, there is so much happening, as I put in the chat, on the policy front. And Eric referenced the Golden Compass model at UCSF. And so there's been funding in both New York State and California to do to test drives of these programs in other locations at FQHCs and Ryan White funded care clinics. But that whole model is really predicated on and there's two ways you can do this, but that model is predicated on the HIV specialist becoming informed to geriatric care, and then having a clinic setting where they have access to the ancillary services that they identified that people may need. And that's the ideal one, and the one that most patients would want, because they're used to being cared for by HIV specialists and infectious disease specialists. And the complaints you hear now is that, as you say, that it's pretty straightforward to treat their HIV. It's everything else, and they get shunted off to primary care providers, but they don't fully understand the impact of HIV on what's happening to them. They look at somebody who's 15 and say, why are they having all these aging comorbidities that typically happen in somebody 15 years older than they are? And then the psychosocial issues are completely, if you haven't worked with this population, are a complete mystery to a lot of providers. So it's, there's a right way and a wrong way to do this. And granted, I'm a little biased, but I think that, so in terms of advocacy, going to your Ryan White planning councils, HRSA, and so forth. And a lot of us are working with the Federal AIDS Policy Partnership and NMAC, the National Minority AIDS Council, to set up meetings to do the research that Karina's referencing, because without the research, you don't have anything to back up the care models you're proposing. So it really is an iterative process. But we've got to be doing both now, because the need is now. We haven't addressed it, and it's mushrooming, and it's really exploding. So we've got to kind of fight this battle on a couple of different fronts, at least, to meet people's needs. I could go on for hours, but I'll stop there.
Thank you so much, Jeff. I really appreciate it, and especially because that's another one of the Dr. Gelly had asked me earlier what sort of surprised me was this idea that a lot of older people living with HIV have this incredible sense of uncertainty as to whether the symptoms that they're experiencing are attributed mostly to the HIV or to aging itself, and it's just like a big question mark that it's lingering.
William, you had another comment?
Yes. First, I wanted to thank Dr. Char for publicly stating her position. I have been going to so many different meetings, and we're hearing everybody but physicians saying that about switching from having a infectious disease doctor manage their care and going to either can't think of the professional word, elder care or a regular primary physician for treatment. And that is like kind of scary for those of us who have, for myself, I've only had my HIV managed by infectious disease specialists for the 20 years since, I recognized that I even had it. And that's a hard thing to do when back then, when you were told, well, this is the doctor you definitely have to see him or her for this. and then I'll manage everything else that your doctor can hear, but that could handle. So teaching us older ones how to ask the questions, is this beneficial for me? And what is the beneficial for me seeing a different type of practitioner for that when right now I don't have any issues. I go every 3 months because I want to, and I've been asked to come once a year, but I'm scary. I'll be the first one to tell you I'm not going once a year. But doing that and having a doctor come out and say that, I kudos to you. I thank you so much for even doing that. Thank you very much.
That's kind. Thank you.
Okay, other questions? We'd love to hear from others who have something to share. You don't have to ask a question. You can just have a comment. It's love to hear from other people. Oops, I hear somebody from 267-379. Do you have a comment you'd like to share? I don't know who it is. It's a phone person. So maybe we can pick up. I mean, I know that it is it's a complicated issue, but I think really what Char's angle is here, and I read this also from Vicky, is that the solutions may need to be policy solutions. Dr. Lynn, Vicky Lynn, says all people, whether they're living with HIV or not, should receive integrated care services from interdisciplinary teams that provides biomedical and behavioral health specialists. So, well, Dr. Lynn is a colleague, friend, and social worker where we always believe in the bio, psycho, social, sexual, spiritual model, right? It's hard to cleave off one piece of that without affecting the others. She goes on to say that our system of care is very fragmented, which makes it difficult to navigate and difficult to provide or receive continuity of care. Dr. Lynn, I don't want to put you on the spot. I just think that's so beautifully said. I wondered, could I put you on the spot? Would you like to say something, or maybe somebody else who relates to that? We see this not just in HIV either, right?
Hi, everybody. This is Vicki. Yes, I'd like to. We see this all over the healthcare system. I've taken care of many friends, loved ones not living with HIV who it's so complicated. We got to go to this provider on Tuesday, this other provider on Thursday, another one next week. No one's talking with each other. There's very little communications among providers who share the same clients or patients. So it makes it very complex. That puts a heavy burden on the person that needs the care. So on top of not feeling well, on top of trying to remain healthy, remain in care and treatment, they're having to navigate this system of care that is very challenging to navigate. And oftentimes clients or patients might not even know what questions to ask. And because they don't know what questions to ask, sometimes they fall through the cracks. Medicaid expansion plays into that. And then Ryan White, in the state of Florida, patients have to renew that every 6 months. If you fail to renew your Ryan White, you cannot be seen by a provider in the Ryan White care system. So say somebody's car breaks down and they miss their Ryan White appointment and they have a medical appointment next week. If they go to that medical appointment, the physicians are refusing to see them because they did not complete their Ryan White. So then they're sent back home. You need to make an appointment with Ryan White to redo this authorization before we can see you. And for, we know the Florida public transportation system. If you don't have a car and have to ride the bus to do these sorts of things, it makes it very, very complicated. And I will get off my soapbox because I could talk for a long time. Thank you.
No, I'm so glad for your contribution. Eric, I saw you nodding, smiling, and shaking your head. You agree. Yeah. All right. Jeff also says a couple of things in the chat box. One is that oftentimes symptoms are trivialized as, quote, just aging when it's more than that. And also this idea of returning to peer advocate, peer navigator model. We have about less than 10 minutes, about 9 minutes to go. And so, Eric, I wondered, what would you like this audience to leave with? I mean, if we can assume that we all have some interest in HIV and aging, and we all want to be advocates, but we all have different, we're doing different things. What is kind of like the take-home message here, or messages that you would like us to leave? Right now, I think you are pretty much the expert here, having read these articles, probably you and Kara. And so and the process of writing kind of, puts these, you have it in your head. What are the highest level messages that you would like us to leave about this issue? And maybe if you can, add in something that we can do or should do.
Sure. So I think my great big grand takeaway message is that the biological, psychological, psychosocial, social aspects of aging while living with HIV are all inextricably linked. And if there's something that you're looking to do now, I think that a number of these issues are already addressed in the gerontological literature. I think that what we need to do is to look to that aspect to see what's already happening, specifically related to intervention work, and to adapt it to this population of older people who are living with HIV. The toughest part about navigating this whole process, right, is that a lot of these issues that were brought up, like verbatim from participants in these studies who are older people living with HIV, are issues that are applicable in a number of other conditions, but we're seeing that, like, the continued failure of our healthcare system to adequately address these. So in whatever aspect of research or community or advocacy that you work, push for these broader, sort of more comprehensive approaches to healthcare. As Dr. Lin had mentioned, it's that, like, defragmented approach that may or may not have worked previously, but it's obviously, not serving us in the way that we need now. So, yeah.
It's this a la carte approach to medicine without treating the person as the whole. The other thing that I think you're talking about, but Jeff touches on as well, is that we may not be talking about I don't think we're talking about reinventing the wheel. We should borrow from existing paradigms and adapt. And where issues overlap, then then they overlap, and then we build out in the specificities. So, well, Eric, I really want to thank you again and congratulate you on this work. Somebody said it earlier in the chat. I think it was Dr. Dubé. We hope this gets hundreds and hundreds of citations and leads you to your faculty job. I know you still. I'm maybe getting a little ahead of myself. I already have you graduated, but really congratulate you on this. And I see you have your email up on the screen, so certainly that's an invitation for anybody here if you'd like to learn more or contact. I was going to say Dr. Reese. It has such a great role to it too, soon to be. Please write Eric at that email. Otherwise, I do want to let you know that in a month from now, we will be having another journal club as part of the Access Lab, presenting a paper co-authored by Kara Green and other collaborators on another project. I'm also on that paper, and that one is about the impact of incentives on clinical trial participation. So you'll get an invitation for that one as well. Thank you so much for joining us today, and good afternoon. And thank you, Eric. Good job.
Thank you, everyone.
Goodbye.
Bye, everybody. Thank you, Eric. Great job.
Thanks.